Well, then for 20 years we've been using warfarin to reduce the risk of stroke and atrial fibrillation, and there's been a call for all of that time for alternatives. And in the last 2 years, these alternatives have finally come along. We've just got the bigatrin, a thrombin inhibitor approved a year or so ago by the FDA. It's known as Pradaxa, and in fact last week the first factor Xa inhibitor, rivaroxaban, was approved. So we now have finally a choice for patients who are at risk of stroke with atrial fibrillation, an alternative to warfarin that's been long sought after and long needed indeed. And so the bigatrin, or Pradaxa, as it's called, is now approved and available. It has many advantages. It does not require the monitoring that warfarin requires. It has a fixed dosing for most patients, but particularly has to be adjusted in patients with renal failure and the elderly. It doesn't have as many drug interactions as warfarin, but it still has some, which are clinically very important. No food interactions, and it doesn't require the monthly monitoring of INRs that warfarin requires. It has some disadvantages, of course. Not everything comes for free, and some of these disadvantages include it's a twice daily dosing. There's no easy way to monitor it, and there's no easy antidote. As with warfarin, vitamin K was a simple antidote. There's no easy antidote for Pradaxa.
But it sounds like with the new medications that it will be more efficient overall, which would affect cost.
Well, we have a large trial, the RELY trial, published in the New England Journal 2 years ago, comparing 2 doses of dabigatran with warfarin, and showing that the higher dose of 150 twice a day was superior to warfarin in terms of preventing stroke and systemic embolism. So this is now a very good alternative for patients, particularly for patients who travel or patients who don't find it easy to have the routine monitoring.